Okay, 5. Very good. Yeah, so these are a lot easier when you have an excision and you can see the scar and then you can see normal tissue next to it. When you have a small shave and no clinical photo or history, it can be much harder because scar is hard to recognize at first, I think, when you don't have practice. Because, like, see, like here, your eye just sees pink in the dermis and there's not much cellularity. So it's sometimes without practice, it's easy to say there's nothing in the dermis. The dermis looks normal. But when I go back here, the dermis is not normal, right? The collagen pattern is different here. There's like this, the bundles are smaller and packed closer together as opposed to the big, chunky, thick reticular dermal collagen bundles. And also there's more vessels and the vessels are pointed vertically. So you know that those are all clues to scar. But I think though that that's one problem is that when you have a small sample of a scar without any normal dermis, or a small sample of any time where there's abnormal dermal collagen, morphia, things like that, it's harder to interpret that when you don't have normal to compare it to. So anyway, there's pigment up at the top, kind of almost looks like a lentigo, but when we look closer, there are actually nests and a lot of single cell melanocytes trickling along the bottom here, these bigger guys that are kind of atypical, and don't have as much pigment. They're trickling along the bottom. There's a lot of pigment in the background. There's pigment in the melanophages in the dermis. So you see this and it looks like almost confluent. The cells are a little atypical. You might have a little bit of pagetoid spread. All those things are things that would worry us for melanoma. I mean, this case is not the most dramatic example mimicking melanoma, but some cases can be quite atypical and very closely resemble melanoma, but this is just a benign nevus that has recurred. And so it's important to recognize the scar. It's important to recognize the clinical history. Ideally, I want to either have a known history of a biopsy with a benign nevus at the site, and also even better is if you can find some of the remaining nevus to the sides of the scar or under the scar, which you don't always get that. But here we have a little bit. Look right down there. It's a bit of congenital pattern nevus trickling through the dermal collagen right at the interface of the scar and the normal dermis down here. So that's a pretty nice clue. You don't always get that though. So if they had a benign nevus and now they've got pigment in the scar and you guys take it out for me and I see atypical stuff, but it's confined only over the scar and we know it was benign before, to me, that's totally fine for a benign recurrent nevus. We do not want the atypical things to be going out over the normal dermis to the side of the scar. That would worry us that maybe could be a melanoma. We need to investigate further, check the previous biopsy, make sure the diagnosis is correct, stuff like that. Okay, so see like the atypical melanocytes here, they stop. There they are, and they stop like right here. And then you have a little bit of kind of lentiginous hyperpigmentation. This might actually be the patient's normal skin type. See, their basal pigment actually looks darker throughout their epidermis. So I bet they're somewhat darker skinned patient. But in any case, the atypical melanocytic stuff stops right at the edge of the scar and doesn't go beyond it. So for you guys in derm and anyone watching this, make sure that you get a good history. If you have a pigmented lesion in a scar, find out what the previous biopsy was, get a copy of the path report ideally if it was done at an outside institution. And then also if you're going to get a biopsy, it's great if you can get a biopsy showing the normal skin adjacent to the scar and then the pigment so that we can see that it's not going out beyond the scar. So in the old days, people will refer to this as pseudo-melanoma because it can mimic melanoma. Of course, I would not put that on a pathology report because that sounds scary, but it's important, I think, for us to remember in pathology, these can mimic melanoma, right? Recurrent nevus phenomenon. And you can see the same thing in a smaller, more subtle way in traumatized nevi. If you have a congenital pattern nevus or something that someone's picked and then it regrows over the top, it can have a little zone that looks like this. And so that can be a thing that can trick you too. So recognize this phenomenon.